Hello and welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ, and tonight we're talking about breast density. What is it? How do you know if you've got it? And what difference does it make to your chances of being diagnosed with breast cancer? Well, that's what we're here to find out. We have two panelists who will share their knowledge and experience of breast density with you tonight. Let me introduce you. With me here are patient Ziggy Chan and radiologist Dr. Sugania Reddy. On to our speakers. First, we're going to hear tonight from Ziggy Chan. Ziggy was diagnosed with breast cancer in 2020 at age 44. Ziggy, thank you so much for being here tonight. Tell us a bit about your diagnosis and how breast density came into that.
Hi, everyone. Thank you so much for joining us this evening. As Adele has said, I'm Ziggy, and I first found out about my breast cancer when I was 44 years old, and it happened as an incidental finding when I was pulling duvet across my chest at night, and it was the size of a small marble on my left breast. I typically delayed seeing my GP till June because I thought, like most people, it was all going to go away, which was not a very clever thing to do. In the end, I did go, and the GP thought the initial diagnosis was a fibroadenoma. The next step then was to meet with a surgeon to do a few more diagnostics. Now, I chose to go privately because I had medical insurance. I met with the surgeon in August 2020, and he also thought at the time, given the presentation, that it was a fibroadenoma. But best practice was, let's go with a mammogram and an ultrasound-guided core biopsy first to see what this little lump entailed. Now, bearing in mind, I was also 1 year short of the free mammogram screening at age 45, and I didn't have any family history of breast cancer either, which sort of led to a surprise diagnosis that it was a grade 2 invasive ductal carcinoma when the histology came back from the biopsy. So the dense breast part came into it when I received my mammogram report back, and the surgeon told me that I had very dense breasts and that my breast cancer was not typically seen on a mammogram. I had no previous awareness or any knowledge about the different types of breast density. On my ultrasound report, the came back as extremely dense, Volpara grade D, which is the highest density you can get because it ranges from A, B, C, and D. So mine was D. And I had a volumetric breast density of 30.7%. So this is all pretty scary because being told you've got breast cancer out of the blue is not something that anybody would want to hear about. And the fact that you've got a tricky situation to work with as well, that kind of added to it. It did make me want to read more about breast cancer and the different types of density. So I got most of my first-hand information from the Breast Cancer Foundation website. I found that the literature in there was really helpful and written in a way that I could understand it. My breast surgeon and nurse were amazing, and they were a great support team. And my takeaway message from that is that for everyone to be encouraged to be proactive about getting your mammograms done early. So moving forwards, after my little experience with having diagnosed with it, and I ended up having a left mastectomy along with chemo, what I would like to see is for the age for your first mammogram to be lowered, and that if you do get your mammogram done in the public health system, that you are told about how dense your breasts are, because my understanding is that is not available if you get it done through the public system via the private. I'd like to see more education and resources available if you do have dense breasts, and what you should be doing to help be more vigilant with your screening, and more research into supplemental MRI screening on top of your mammogram and your ultrasound. So where I am now, 3 years on, I still continue to have my current screening regime privately. I have a 3D mammogram now and an ultrasound every year. And I will be coming up for my MRI in a little while. And the last one was done 3 years ago and the start of my diagnosis. I was told that the MRI can be useful, but it will also give you possibly some false positives. It might drive you into over-treatment and raise a little bit of anxiety that's not necessary. I'm also on monthly Zoladex injections to shut down my ovaries because my breast cancer was mainly hormone-driven. And I take a daily tablet of tamoxifen, and I do weekly Residuate for bone density and vitamin D as well. I try to be good. I'm trying to exercise more, have a better lifestyle. Still not perfect, but I think I'm getting there. And I just like to end on a note that moving forwards for breast density awareness, it would be great to see whether breast density could be hereditary, especially because I have a 15-year-old daughter. And also the percentage of women in New Zealand that do have dense breasts, if that data could be available. But I understand that without it having the same system in public and private, that's probably a bit challenging. And that don't leave things too late, you know. So if you know you've got dense breasts, or even if you don't know you've got dense breasts, if you're due for a mammogram or something is not right, go and get it checked out, because early detection makes all the difference. So thank you for listening to me, and thank you for your time.
Great. Thank you so much, Ziggy, for sharing your story. We'll move on now to our next speaker, Dr. Sugania Reddy. Sugania is a consultant radiologist in both private and public practice, and in private practice in the public system. She has a special interest in breast density. Sugania, we really appreciate you joining us tonight. Thank you. Can you tell us what exactly is breast density and why is it so important?
Thanks for the introduction, Adele, and Ziggy, thanks for sharing your story with us. That was really good to hear. As Adele has mentioned, I'm a radiologist, and I'm here tonight to talk to you about breast density. Mainly, what is breast density? How do we assess it as radiologists? And what do we do in our private practice with patients that are dense? So to start off with, what is breast density? So the female breast has fibroglandular tissue and fatty tissue. The fibroglandular tissue is the tissue that has the breast ducts, the lobules, the fibrous tissue, and the connective tissue. This is where breast cancer develops, and you can't actually feel how much of fibroglandular tissue you have. It's usually something that we see only on a mammogram. And so a breast density assessment is basically an assessment done only on a mammogram. It's not really what you feel. So how we assess breast density, it's the relative amount of glandular tissue to fatty tissue on a mammogram. So the glandular tissue appears as this white tissue on the mammogram, and the fatty tissue as a very dark tissue on the mammogram. So if you have more white tissue, then you would be more dense, and that's what we consider high breast density, greater volume of fibroglandular tissue. So our assessment is based on a Barretts classification for breast density, which is an American College of Radiology classification, which has grouped breast density into 4 big categories, which is basically a density A, which is mainly fatty. And as you can see, there's very little white tissue on that first image. And as we go through the different densities to an extremely dense mammogram, you can see that there's lots of lots of dense tissue, lots of the white tissue on that mammogram, and very little fatty tissue on that mammogram. So how do we measure breast density as radiologists? So basically, this can be done in 2 ways, either subjectively, where a radiologist reviews your mammogram and is able to have a visual assessment of the amount of fibroglandular tissue versus the fatty tissue, and then assigns a Barretts breast density score to your mammogram. Or it can be done in an automated way where there's a software program, and in New Zealand and in our practice, we use Volpara, which it basically gives us a scorecard that is generated after it analyzes your mammogram. And it's a more objective way of looking at breast density because it actually looks at every pixel and decides on how much of each pixel has dense tissue versus fatty tissue. So what it gives us is a percentage of breast density, and it also gives us an average breast density volume, which we call VBD. Now, the importance of that has been that we've been able to use VBD in risk assessment tools like the one that's actually up on there, which is the TC8. The TC8 basically allows us to add a patient's density together with their other risk factors to assess a lifetime risk. So you can see that Volpara scorecard gives you a breast density from A to D, which is in keeping with the ACR Barretts breast density classification and those categories. So why is breast density important? The two main reasons breast density is important is because, one, it has a masking effect, which I'll discuss now. And the second thing is that it's in itself a risk factor for breast cancer. The masking effect, if you look at the left image on that side, the very first image shows a very fatty breast where the tissue is really dark. That speculated white lesion that you're seeing in there is what we would see as a cancer on a mammogram, and it shows up as white on a mammogram. And in a background of a very fatty tissue, you can appreciate that that's quite easily seen. Whereas in a denser breast, which has got a lot of white tissue, and you have a lesion which is also white against that, the likelihood of actually picking that up is lower. So on the right image, you can see again, there's a little stellate lesion in the center of that breast. And you can easily see it on a density A and B. And as you're getting towards a C and D, you actually lose seeing that little stellate lesion. So the dense breasts are regarded as mainly a C and D, and the non-dense breasts are the A and B, and therefore you can see lesions much easier on a non-dense breast than a dense breast. So what does this masking effect actually do? It actually reduces us picking up a cancer on a screening mammogram, and it increases the interval cancer detection. And by that we mean you can feel a cancer between screening mammograms, basically. So you've come in, you've had a screening mammogram, it was normal, or there was no abnormality found, and a few months down the line, you feel something. So it's a palpable abnormality. It's a cancer that is picked up because you can feel it and not because you had a mammogram and we actually found that. So the idea of the screening mammogram is to actually find a cancer that is not palpable when it's really small. And therefore, interval cancers are usually cancers that are larger. They have a higher stage of disease. They would have metastasized to lymph nodes sometimes. So, you know, our priority with screening is to try and find these cancers when they're smaller and not when they are palpable. So the masking effect is an issue for a denser breast. As I said, the second most important thing about breast density is that it's in itself a risk factor for breast cancer. So let's put that into perspective a little bit. On average, most women in our population or in any population would have a density B or C that would account for about 80% of patients. An average breast density, therefore, would be between a density B and C. And if we have to look at a relative risk for a breast density C to an average breast density, that would be 1.2. If we had to look at a relative risk for a density D compared to an average density, it would be 2.1.
Thanks, Agania. And I just wanted to have a quick word here about what this idea of relative risk is and what these numbers actually translate to in percentage terms. So in New Zealand, we say that 1 in 9 women will develop breast cancer in their lifetime. And that's basically means you have about an 11% chance of developing breast cancer. So if that's the average risk and you're in the density C category and you've got that 1.2 times risk, that's going to put your average risk in your lifetime up to 80 years of being about 13%. So up from the 11%, 13%. Obviously, the 2.1 for category D is quite a lot higher. And so it's going to put your risk up to about 23%, which is a high percentage of likelihood of developing breast cancer in your lifetime. So yeah, I'll hand back to you, Siganya. Thank you.
Okay. So this slide is actually quite an interesting slide. This is a study that was actually done on over 100,000 mammograms. It was with a Dutch screening program done between 2003 and 2011 and incorporating age groups of about 50 to 75. And what was measured there was the breast density of those patients. Obviously, they found 667 screen-detected cancers and 234 interval cancers in this group. But this table is quite an interesting table because you can see that all of their patients were categorized according to a density A to D, as we've just discussed. And as you can see, firstly, that most of those patients, again, were in that group of density B and C, and only a small percentage were density D, which we think is usually about 10% of the population. But we can also see that the cancer detection rate definitely had increased over increased densities, as you can see. And the density D, interestingly enough, had a slightly lower cancer detection rate compared to a density B and C. And obviously that is probably because of that masking effect that we spoke about. The interval cancer detection rate, as you can see, was unfortunately quite a high interval cancer detection rate for density Ds compared to the other densities. So that too had increased over the different densities. And then the last column is actually the sensitivity of the mammogram. And you can see that the sensitivity of the mammogram with the density A is quite significantly high. It's about 86% compared to a density D, which is reduced to about 61%.
Interesting.
Okay, so it is about masking, it is about sensitivity reduction, and therefore, a slight reduction in cancer detection and increased in interval cancer rates in patients that are especially a density D. Okay. So this is a slide just showing again that density B and C accounts for about 80% of our patients, where we have really good mammographic density and we are able to see cancers quite well. Especially in a density C, I think that tomo, although it's a dense pattern, tomo has helped us in terms of being able to actually differentiate cancers from the adjacent breast tissue. So now that we know that there's, different densities and that some of those densities have a higher risk for breast cancer, and we can appreciate that the mammographic sensitivity is reduced, what can we do about it? And at the moment, there's lots of debates and there's lots of discussions and tons of data, for supplementary screening, which increases the cancer detection rate, and especially patients that have very dense breasts. So we have breast tomosynthesis, which basically is like getting a mini CT scan in a way of your breast. They find 1 millimeter slices that are reconstructed, and that allows us to scroll through a mammogram, which it is not a static image like our standard 2D mammograms, and allows us to separate tissues from lesions, and has a increased cancer detection rate of invasive cancer of about 30% apparently. The other modality that we can use for supplementary screening is breast ultrasound. Now that can be done in 2 ways. That could be either handheld ultrasound done by a sonographer or breast radiologist, or it can be an automated breast ultrasound where you have a machine actually taking images, and that's analyzed by a radiologist. And then obviously the third supplementary screening modality we have is a contrast study. Now, there's a lot of data supporting MRI, especially abbreviated breast MRI for supplementary screening in patients that have dense breasts. But there's also contrast mammography that is also being used in lots of centers where MRI is not available. This is a study that was done quite a long time ago in 2010 by Professor Cool, but it's a good slide in that it shows us the different modalities, and it also shows us the cancer detection rate by adding supplementary screening. So if we start with a standard mammogram, you can see that the cancer detection rate in this study was about 5.4 per 1,000. If you add ultrasound, you have increased that cancer detection rate to almost 8, about 7.7. So mammogram and ultrasound definitely, adding ultrasound has had its benefit of further cancer detection. You add MRI, and there's obviously a very much bigger jump. Now you're looking at about 15 per 1,000. And the study has shown that adding MRI to mammography is probably the best with 16 per 1,000. Adding ultrasound to that doesn't necessarily change that cancer detection rate much more than that. So all of this is great that, there's a great cancer detection rate with supplementary screening, but implementation is still a very big question, and the difficulties in being able to actually find a cost-effective way of doing this is one of the big issues. So I've just added this slide because I think that, a lot of patients ask me specifically, what can I do about changing my breast density, And unfortunately, a very large proportion of patients, one of the biggest influences for breast density is just genetics. If your mom's had a high breast density, your sister has it, your grandmom's has it, the likelihood is that you're probably going to have a very high breast density too. Some studies have shown that people living in an urban environment have a higher breast density than those in a rural environment. Reason being that, they think urban pollutants probably contribute to that. Ethnicity, which I'll discuss in my next slide in a bit more detail. So, different ethnic groups have different risk for breast density. They found that patients with a lower BMI have a higher breast density. And things like alcohol and use of HRT increases breast density. As us women get older, our breast density actually reduces. So, getting older is great that you can actually reduce your breast density by getting older.
Something good about it.
Yeah. Tamoxifen, of course, reduces breast density as well. Okay. So coming back to the ethnicity, studies done internationally, especially in the US, show, patients that are Afro-American specifically have very high breast density. There's very little data, unfortunately, in New Zealand. I could only, give reference to this one study at the moment that I know of, which was published in 2013, which did show that Maori women in our population do have a higher volumetric breast density compared to the rest of our New Zealand population. But the study also showed that Asian women have a low volumetric breast density. And I think the key word there is volumetric, because if you're dealing with a smaller breast, the volume of dense tissue would be less. And I think that's where that basis comes from. But, in our practice, we've seen a lot of Asian women with quite high breast density, I must say. Yeah.
Like Ziggy.
Okay. So what data do we have for supplementary screening? So there's lots of data, but I think the two biggest trials are what I'd like to have a show reference to. This is the DENSE trial, which was actually done in the Netherlands and had a publication. The first publication was done a couple of years ago, but the most recent publication, which was done only towards 2020, basically shows a second arm to the study. So the very first arm was basically women that had extreme breast density. So it was specifically women that had extreme breast density and had negative mammograms, so a normal mammogram, was invited for MRI screening. Of those, there was about 40,000 on the initial, in terms of the initial pool of women with extreme breast density, but there was only 4,700 from that pool that went on to get MRI. The cancer detection rate in those patients that had the MRI and had a normal mammogram prior to that was 16.5 per thousand. And those patients were followed up, and so were the rest of those patients that actually chose not to have the MRI or weren't offered the MRI. And 2 years later, the follow-up basically was quite interesting because it showed that the interval cancer detection rate had significantly reduced in those patients that had MRI. And that reduction was 0.8 per thousand versus those patients that didn't have MRI, which was 4.9 per thousand of those that weren't invited for MRI, which was about 5 per thousand. So I think, the idea behind that is the fact that MRI obviously picks up, is you having a contrast injection of a dye that picks up the actual tumor vascularity and shows up easier because of that. And it's not a study based on morphology only. So whereas mammography and ultrasound, we are looking specifically for a mass, whereas with MRI, we are looking at the dynamics of what the tumor does, and in terms of the tumor vascularity, how it takes up this dye, and therefore it's easier seen. The second big trial was a trial called the EA1141 trial, which is actually a trial initiated mainly by Professor Cole and done at multiple centers, both in Europe and in the US. And what this trial was, it basically looked at abbreviated breast MR and compared it to patients that had digital tomosynthesis to see what the cancer detection rates were. And for an abbreviated breast MR, what it basically means is our standard MRI protocol has been reduced to a protocol that just is designed to look at enhancement mainly. So it's a much shorter protocol. In our center, we've managed to reduce our full MRI protocol from 30 minutes to 10 minutes. And by having reduced magnet time, you're actually reducing the cost of that study quite considerably, so that it allows more patients access to it. So that's the idea behind it. So they compared abbreviated breast MR to DBT, and they found once again that abbreviated breast MR had a higher cancer detection rate. Again, in the study, it was about 12 per thousand or 13 per thousand versus tomosynthesis, which is 4.8 per thousand. Okay.
Scania, someone's just asked what an interval cancer is. Can you just explain that before we move on?
So an interval cancer is basically a cancer that occurs between screening mammograms. So meaning that if you had a mammogram every year and you developed a cancer immediately after that, before your next year of a screening mammogram, that would be considered an interval cancer. If you're in a 2-year program, if you have a mammogram and before your next 2-year mammogram, you develop a cancer, then that would be considered as an interval cancer.
Thank you.
Okay. So there's lots of discussions presently, and a lot of guidelines have come up around the world. To start off, I'd like to say that our college is currently updating their breast density position statement presently. So, I'd like to just quickly let you know about other countries that have, had rulings already. And in the US especially, there's been FDA approval as of March this year, where there's been a ruling requiring all mammogram reports to inform patients of their breast density, and that breast density is a risk factor for breast cancer, and to advise them to speak to their providers about having screening beyond mammograms, so supplementary screening, which we've discussed, to help increase their cancer detection. Also in Europe, for instance, at USORBI, which is the European Society of Breast Imaging, has also come out with a similar statement where patients should be informed about their density, and also offered to help with, letting patients know what their choices are. They do recommend supplementary screening for patients with extremely dense breasts with MRI, preferably 2 to 4 years. And if MRI is not available, mammogram and ultrasound as a good alternative. They also recommended that there should be quality assurance systems in place for the supplementary screening. So, us in New Zealand, unfortunately, because of the lack of local data, we in our practice wanted to actually see what supplementary screening can offer our patients in our setting, which is a private setting. And so this is one of the studies. Our trial still comes to an end only in about a month's time, so we will be processing our data to get more information from that. But so far, we've had a couple of cases where, just like the international data, there has been some support for supplementary screening, finding more cancers in patients that not necessarily were just dense, but we used a risk assessment tool which did include breast density, and offered those patients that had higher breast density, higher risk, which included a lot of patients that had high breast density, to have supplementary abbreviated breast MRI. So this is a case where this patient had a screening mammogram, and this was a routine screening 2D mammogram, which basically showed a very dense breast pattern and was read as, no cancer detected on this mammogram. She had an abbreviated breast MRI as a screening MRI in the study that we were doing, and unfortunately, she had multifocal breast cancer in her left breast. You can see all those enhancing lesions. Those were all masses. There were about 6 masses that we detected on MRI. And unfortunately, those were invasive breast cancers. She ended up having a left mastectomy. The interesting thing is, if you look at those images, while her mammogram is extremely dense, that hasn't necessarily caused a big masking effect on her MRI. And in the real world, it would be great if every patient was like that. But there are some patients that we do not have that benefit. And if they screened at a time in their cycle where, their tissue is very hormonally receptive and we have a lot of background enhancement, that does cause a slight reduction in the sensitivity of the MRI. But in a lot of our patients, we find it quite interesting that, they will have a very dense pattern, but it wouldn't really transform to having a big masking effect on the MRI. This is another patient that had a very similar effect. You can see how much more dense this patient is actually. So she had an extreme breast density, she had a moderate risk, and we did an MRI. Her mammogram was obviously normal. And we found that she had multifocal left breast cancer as well, multiple enhancing masses. Also, she had a bit of non-mass enhancement, so that's suspicious in the area for her mass enhancement. And you can see she's got disease from the posterior aspect of her breast right to the anterior aspect. We also can look at the contralateral side, and in this case, she actually had a lesion on the other side, which we did work up, and it was actually a benign lesion. So, that's where the issues come in, is that sensitivity is really great, but sometimes specificity is an issue. So what do we do in our private practice with patients that are dense? So to start off with, radiologists read a mammogram. We do have a breast density assessment. We use Volpara. That's added into a report. We inform the patient that this is what, that she does have extreme breast density. So patients specifically that have extreme breast density, we would recommend supplementary screening. And usually by just talking to our patients, and explaining that this is what we want to do, I think it does reduce some of that anxiety associated with being told that you have an extreme breast density and that it does have a risk for breast cancer. We all, in our practice, usually we will offer these patients an ultrasound if we feel that their mammogram is has significant reduced sensitivity. And also because ultrasound is very much easily available right on our site, the costs of it is much lower. If it's a patient that has a high risk, we would recommend screening breast MRI for supplementary screening. We also do send a report out to your GP and inform your GP about your breast density so that you could have a second discussion as well with your GP about this.
Great, thank you so much, Sudani. That was extremely helpful, and I think everyone is a lot better informed than they were when they arrived tonight, so thank you for that. Just going to, before we move on to questions, people have been commenting a little bit in the chat, and they talk to us at Breast Cancer Foundation quite often about the fact that if they have their mammograms through our excellent breast screen Aotearoa program, they don't find out if they have dense breasts. That's really, as you say, that's something that tends to happen in private practice. So as helpful as tonight's information will have been, it's hard to know if it applies to you, if you're in that situation. It's hard to know also what you can do about it. So we at Breast Cancer Foundation do think that's a problem, that you may not be, that you're not told your density level if you're having a publicly funded mammogram, and it can put you at a disadvantage. For example, if you don't know you're at higher risk of a hidden cancer, you might not be so concerned if you felt a lump between your mammogram. Now, we'd always say get every lump checked, but that just might not happen if you're not sort of aware that you have a risk factor. So before we move on to questions, I'm just going to share a couple of slides with some perspective from Breast Cancer Foundation. And so we're going to think about what could happen today and about how in future women with dense breasts might be able to be supported through a screening program. So what could happen in public screening? We've heard about what does happen in private screening. It's certainly at this one clinic at least. And so what could happen in public breast screening? Well, it's really important to think about the context here. And there are considerations for women who go for public screening who don't have an MRI on offer to them if they do find out they have dense breasts. So the implications of finding out that your breasts are dense, what does that mean? And we know that there are studies showing that it can make people feel more anxious, but at the same time, there's an opportunity to be more vigilant about your breast health and so on. And then considerations for the health system. We know that our health system is under-resourced and struggling with costs, so adding additional costs, adding new screening technologies that may not be available and that may not have capacity. These are all considerations to think about as we talk about what could actually happen in our public screening system. But there is one thing that could happen pretty quickly, actually, and that we would see as a top priority, that women and their GPs should be informed about their breast density. Now, there's a few reasons to do this. Women are already concerned about breast density, and we know that by the fact that hundreds of people registered for this webinar tonight. People have heard about breast density in the media, they've heard international stories, they've seen stories of local Kiwi women with dense breasts, and so many Kiwi women do actually now want to know their density. As we've said, being aware of your density encourages you to keep an eye on your breasts and discuss any concerns with your GP. For some people, there'll be the option of private additional screening. Sadly, not for everyone who can afford that. Can't afford that. If your GP knows your breasts are dense and you have some kind of suspicious lump or something like that, the GP can more accurately assign a suspicion level when they refer you to your breast clinic. The GP sends you off to the public hospital for an assessment. They tell the hospital if they have a high suspicion or a low suspicion that you've got breast cancer. Knowing that you had extremely dense breasts might help them give a more accurate suspicion level. So there's lots of good reasons to understand this, but conversely also need more information and really good information if you're going to tell people about their breast density. They need information to reduce any anxiety they might experience and help sort of put that in the context of what it actually means, and to encourage them to continue with regular screening as well as whatever else can happen, because we do know that mammograms do find cancers in dense breasts just to a lower extent than in a less dense breast. That kind of information is readily available in private practice, and Ziggys has talked about how they talk to patients about that. That's not something that happens in public at the moment. So that would be a top priority. Another high priority would be the kind of screening that Ziggys has been talking about, additional screening for women in that top 10% of the population with the extremely dense breasts. And Ziggys has already talked about what those options might be: mammogram and ultrasound, MRI, and so on. And then at a lower priority, those women with the heterogeneously or mixed dense breast, what else could happen for those people? And maybe we've seen recommendations overseas that it's an annual mammogram, for example. So there'll be other options to consider there. And as a evidence-based screening system, our health system likes to rely on evidence of what's been going on overseas and in other screening services and other health services. So certainly if there are opportunities to pilot alternative high-risk screening here in New Zealand, that seems like a sensible kind of thing for us to do. Right, that's it from me. Right. Ziggys, I just noticed a few questions popping up about the cost of an MRI. Can you give us some ideas of what are people up for if they do want to go ahead with this?
So the abbreviated breast MRI, as I said, has been designed to actually reduce costs, and because we have reduced magnet time, we can afford that. So on average, a breast MRI in private would be about $2,000. An abbreviated breast MRI would be about $1,000.
Right. Okay. So still a substantial sum of money.
It is still a substantial sum of money.
Yeah. And is abbreviated MRI widely available?
I think a lot of private practices, as well as the public system, do have abbreviated breast MR. I think it's been something that over the last couple of years has definitely come to New Zealand, and more people are doing it now. So I do think that it is available.
Just a really practical question. Do you do an MRI face down?
Yes, unfortunately so. So, you know, when the beings designed our magnets, they actually felt women should be lying forward when they do this. And so we do have patients prone. And that's why having a shorter protocol for a screening protocol is really great. I remember my very first patient that I had on the table actually had a previous knee joint replacement, and she was undergoing these long screening MRIs for many years. Every year she would have one. And when she had the reduced protocol, the abbreviated protocol, she almost got off the table and hugged me at the end of this because it was so much better, so much more tolerable.
Yeah.
And that's the issue, is that, you know, there's definitely a group of patients that don't tolerate MRI. So contrast mammography has become now the next best alternative. And a contrast study, there's very few centres, unfortunately, in New Zealand doing contrast mammography. And the cost of those about $800 as well.
Right, right. Ziggy, a comment for you from Kate Friedlander says hi, and she's sorry to hear you were afflicted with breast cancer, as she herself has been, and thank you very much for sharing your story. She also says you're looking great. No, which we would have to agree with. Ziggys, a bit of a question about the risk associated with breast density. How much of that is due to masking and how much is due to additional breast cancer risk?
That's a hard one for me to answer, I think. I think that, you know, both factors play a very important role. The masking effect obviously plays a role in the fact that we don't pick up the cancer when it's really small, and lots can be still done with it. The risk of having breast cancer because you have a higher breast density, you know, makes us want to actually make sure that we try and use all the right tools to find what we need to. So I think that both those do play a role quite significantly. I can't really say that I would be able to separate that.
And is there currently in the public system any supplementary screening offered? I think my understanding is that high risk screening is down to each district, and it's probably not density focused.
Exactly, it's not density focused, but that's why, like even the pilot study that we did, you know, capacity is a big issue. So I do think that, firstly, as you said, you know, there's issues of anxiety, there's issues of resources, having enough magnets, having enough staff to run that, and dealing with the cost of that. We can't say every dense patient should have an MRI. There's also the issues of false positives, which result in patients needing to get further imaging and biopsies on lesions found on MRI, which is also another added cost. So in that respect, I think that so far our, you know, public system mainly has screening MRI for patients that are high risk and not necessarily high breast density.
Right, indeed. And around those risk factors, there's a couple of questions about the difference it makes if you have more than one risk factor, excuse me. So for example, if you have a family history plus high density, or if you have calcifications, microcalcifications in your breast plus density, do those things combine, or how does that work?
Yeah, so that's what we're trying to figure out with the study that we've done recently, because just looking at density as being the only risk factor and deciding this is the supplementary screening that you have, you need, is quite actually, it's difficult to put that into a perspective which is going to be affordable and sustainable. So I do think that looking at all the risk factors in combination, and that's where the big problem, a lot of the risk assessment tools previously never had breast density included in it. So a lot of our programs were designed based on just family history, a genetic, you know, familial history of breast cancer. So in saying that, the TCH was one of the first that came out with adding breast density. And there's one other risk tool now, which is BCFNZ version 8, that actually has breast density added to it. And if you add all of those factors, and it's not just familial history, it's also basically things like patients' body weight, previous high-risk lesions that patients may have had. I spoke a bit about ethnicity, but also other risk factors like if patients have had, you know, lifestyle changes. All of those are included in lots of the risk tools that can give an overall risk and say, okay, these patients are higher risk and they probably need to have supplementary screening with MRI. In terms of calcification, I just would like to go back to that. Calcification, a lot of the calcification we see on a mammogram is actually very benign calcification. And the microcalcification, which is spoken about, that needs to be, you know, worked up and biopsied, is usually clustered calcification that looks irregular on a mammogram, and that we can see is probably going to be what we call DCIS, in situ cancer. And those are patients that will be in a more diagnostic pathway rather than patients down a screening pathway.
Right. Okay.
And they have an MRI to see full extent of their disease, but it's prior to, you know, they would have had a biopsy confirming their diagnosis before that happens anyway.
Yeah, and we have a couple of other questions around that with MRI and people who either have had a diagnosis of breast cancer. So someone has asked, so she's been treated already for breast cancer and now she's going back for follow-up screening or follow-up checks. Should she be inquiring about her breast density when she has her campaign?
Yes, I would think so. I think that, you know, patients that have had especially breast conserving surgery, and if they're extremely dense, that's a discussion to have with your surgeon as well, as to whether, you know, you'd be benefiting from having supplementary screening MRI to your mammogram when you're doing your annual screening. A lot of patients that have had previous lobular cancers will get a screening MRI as well. But, you know, for other patients that have high breast density and their cancer was not really seen on their mammogram initially, I think that that's a discussion that you need to have with your surgeon about what your screening should be.
Right. Yeah. Okay. Thank you. And let me just see. I think there's another one here from someone who had been diagnosed. So you might pop back to that one. It's not quite on topic. Let's. Does thermal imaging work for breast density?
No.
Okay. Short and sweet. Can you explain volumetric breast density, which is a term you've talked about a couple of times?
So the amount of glandular tissue. So the breast, when we look at it as a mammogram, and you saw that density D, where that entire mammogram looked like it was a complete white mammogram. And you would think that I've got 90% breast density on that. But what the volumetric breast density is that the breast is not a two-dimensional structure, it's a three-dimensional structure. So it's taking a volume and it's adding, and what the software programs do, which is really great, is that it takes each pixel in that mammogram and actually manages to figure out what percentage is dense and what percentage is just fatty tissue, and therefore gives you a volume based on the volume of the breast. So this is how much of glandular tissue volume you have in this volume of your breast.
Right. Thank you. Thank you. Someone has asked, can we call the centre where our mammograms were taken to ascertain if we have what our breast density is?
So in private, you probably can, because most private centres probably do a density assessment. I do think that, you know, public is still at the moment trying to actually decide on how they're going to manage that. And that's because they have a lot more patients and their resources are going to be, you know, stretched with having to address this.
And someone has asked, can you explain why you can have pain and discomfort in your breast, be told all is okay, but still be having pain?
So there's this story that we used to tell, which we still tell, I think. And when a patient comes in saying they've got a lot of breast pain and they're worried they have a breast cancer, most breast cancers are not painful. So that's immediately something that's reassuring, actually. So a lot of breast pain is more related to benign disease, usually fibrocystic change, usually a hormonal stimulation of the breast. And hormonal stimulation of the breast, I always say to my patients, you know, if you look at your cycle, and it's usually young women that have this situation, and it's very related to their menstrual cycle, and just before their cycle, they get a lot of pain. After their cycle, that's actually the lumpiness and the pain actually reduces.
Okay. And on that subject of fibrocystic breast, someone has asked if screening mammograms are recommended for women with diagnosed fibrocystic.
I think a screening mammogram is always recommended as a baseline investigation for breast cancer. And I think that even when you are told you need supplementary screening, you will still have. And one of the biggest things is we spoke about the calcification. Calcification is only really seen on a mammogram. We don't even see calcification on an MRI. We see enhancement on an MRI, but we don't see the calcification. But the earliest signs to pick up the calcification and DCIS is on a mammogram.
On a mammogram, great. And here's someone who said she's been advised she has extreme breast density, category D, and has had large papillomas removed. Do papillomas increase the risk of breast cancer?
Yeah. So a papilloma is actually a benign lesion, but there is an association. So papillomas can be associated with low-grade DCIS and sometimes with an invasive cancer. So depending on whether it's a single lesion or multiple lesions, so you have a condition called papillomatosis, where you have multiple papillomas. But if you have a single papilloma, usually the surgeons prefer removing them because of the associations that they can have.
Questions about funding about screening women younger than age 45. We know there's some more evidence now than there used to be for benefits. Can you tell us about that?
So again, this is about private and public. In private, a lot of private centres in New Zealand will start screening from the age of 40. And that is because we have seen patients below the age of 40, like Ziggy, below the age of 45 that will have a breast cancer. So there is data to support that patients below the age of 45 can start screening. Also, in patients that have had a strong family history, first degree relative, like the mum has had previous breast cancer, we do ask those patients to screen much earlier as well.
Yeah. And we know that Māori and Pacific women are more likely to get breast cancer at a younger age.
Yes.
So certainly as a foundation, Breast Cancer Foundation, if there was a move towards younger screening, that seems like a really good place to start with people who are more likely to develop cancer at a younger age. Let's see, for high-risk women, high density and previous breast cancer, is MRI alone sufficient for annual screening, or should MRI be combined with mammography?
Yeah, I think that's a very good question. And I think that, you know, as I said, the benefit of mammography is to look for DCIS. And in saying that, you know, usually we're quite good at seeing higher grade DCIS, that's intermediate and high grade DCIS on MRI. Low grade DCIS, again, we rely on it being calcified and being able to see it on a mammogram. So for a lot of our patients, we still think using MRI and a mammogram is probably the way to go.
Would letrozole reduce breast density similar to tamoxifen?
That's an oncologist question, I think. I would like to think so, but I think that, you know, tamoxifen, obviously, any hormone receptive drugs would actually cause a reduction in breast density. And
we can certainly check the answer to that question if there's any strong evidence on that tomorrow. When just about, our time is just about up. I'll just see if there's any other major topic we haven't covered yet.
Can I ask a question? Is there a finite number of MRIs that you should or can have? So say my example of now I'm 48 and there's a recommendation that I should be having an MRI every 2, possibly 4 years. What is then the repercussions of having quite a few MRIs over your lifetime and that MRI contrast dye staying in your system and not being fully sort of excreted? Because you got to weigh this. The conversation I had with my surgeon was, how many MRIs do we give you? Because that dye is going to stay in there. And the second part of that, my question is that, are there any technologies out there that is working on providing a dye that has a shorter half-life in your system and is probably more, I guess, user-friendly? Yeah.
That's a very good question, actually. So there's been a lot of discussion about what we call gadolinium retention. Okay, so the gadolinium is the dye that we use for MRI. And so previously they used to use a different brand of contrast, which used to be what we call linear agents. We now use what we call macrocyclic agents. The gadolinium deposition for macrocyclics has been significantly reduced compared to the linear agents, to the extent that there's tons of data now which actually supports using macrocyclics. So that's the first thing, is that, you know, the type of contrast used now has caused significantly less gadolinium deposition. That's the first thing. The second thing is that there has not been any data to support the idea that gadolinium deposition results in any clinical adversity. All right. So we know that there's a deposit, but whether we can prove that it has resulted in any typical clinical findings, there's lots of cases, as you would know from the US, with, you know, gadolinium deposition in the brain and in the bone and all of those. But up to date now, there hasn't been anything that can support that, really.
And what about the age related? So being diagnosed with breast cancer at the age of 65, the high breast density and all those risk factors, and then needing to have that supplemental MRI. So would that person then just keep continuing at that age that they're at? Or when you're younger, do you reach a certain plateau point where, you know, your interval for the MRI is shortened, or it continues to remain at that 2 to 4 year?
Yeah, I think that it's case dependent. And the reason I say that is if you're a patient that has a very high breast density and you continue to have a high breast density, we know that as you get older, your breast density reduces. But if you continue to have a higher breast density, even as you get older, and your sensitivity of your mammogram is still reduced, you probably still would want to have a screening MRI. And if you're a young patient, and we know younger patients have a higher breast density just by age in itself, then obviously, you know, you would have a slightly reduced sensitivity on your mammogram anyway. But if you are a young patient and by any chance you have a less dense pattern, then, you know, your mammogram is probably going to be a lot more sensitive. So, you know, your intervals for having an MRI is not as needed to have it as regularly as that.
Thank you.
We'll just wrap up. There's a couple of really quick, simple questions that I'll just answer for people. What is tomosynthesis? You might have heard of it referred to as a 3D mammogram. So it is like a low dose X-ray, slightly higher dose X-ray than a 2D mammogram. Tomosynthesis is used in screening in private practice only at the moment in New Zealand, but used for diagnosis in the public hospitals. And someone has asked, can they talk to their radiation oncologist about their density? It's actually a radiologist rather than radiation oncologist that you'll be talking to about density. We'll wrap up now. I'll finish with a question for Ziggy. Ziggy, how do you feel now about your own breast density now that you've read up about it and become a lot more informed about it? Are you less anxious, more anxious? How do you feel about it now?
I think it's one of those oxymoron questions, because when you find out that you know something, you feel more empowered and you become more vigilant. But sometimes knowing can also bring out other things, like you can't help but worry. And if you don't worry about yourself, you worry also for your family. And the key thing is that you can't let yourself spiral into this state where you end up being worse off than what you are. You just got to take it on the chin and say, look, I do know, and be really pragmatic and just be very practical focused and stay on track and try to keep positive and know that you're taking those right measures. And also, if you have friends or family that are unsure, then encourage them also to find out if they can. I think, you know, the empowering thing is being able to share what you've been through, and also to help others. Yeah.
Great.
Thank you.
Okay. Thank you so much, Ziggy and Zigani. Thanks to both of you. That's it for us now. Thank you and good night.